Wonderful. Okay, I think we will get started since we're already a few minutes past the hour. Thank you so much for coming to this High Rounds. I have the great pleasure today of introducing Tyler Bartholomew, today's speaker. Tyler is an assistant professor at the Division of Health Services Research and Policy at the University of Miami Miller School of Medicine's Department of Public Health Sciences. He holds a BS from Hofstra University and a PhD in Prevention Sciences from the University of Miami. And in 2021 to 2022, he was a Johns Hopkins Inter-CFAR Implementation Science Fellow. So Tyler's research is a translational research program. It focuses on leveraging implementation science to develop and improve implementation of innovative harm reduction and health service delivery models for marginalized communities, particularly people who inject drugs and people living with HIV. His research is focused on the infectious complications of substance use, and he really leverages data-driven approaches to improve health services and policy implementation in these populations. Dr. Bartholomew led the research and evaluation efforts of the IDEA Miami Syringe Services Program, which we'll be talking about today, the first legal syringe service program in Florida. And it was really his research and advocacy efforts that translated into statewide legislation, allowing all counties in Florida to implement syringe service programs in 2019. Despite only having obtained his PhD in 2021, I hope he doesn't mention if I highlight that Tyler has, this wasn't in his blurb, I added this.
Right.
That Tyler, got his PhD in 2021, but he has 40 publications and he's PI or MPI on 9 active grants from NIDA, the Florida Department of Health and Industry. He's an investigator in the NIDA Clinical Trials Network Florida Node Alliance. He also serves on the editorial board of Annals of Medicine, Addiction Science, and sits on the board for the Florida Harm Reduction Collective. So a real mover and shaker. We're so excited to have him come and talk about IDEA today. Welcome. Welcome, Tyler.
No, thank you so much, Natasha. And thank you all for joining today. I'm really excited to talk about what has really been the last 6 years of my life. This is more of a story of advocacy, community, research, evaluation, implementation. But really the heart of it, it's hope for clients that are very marginalized in the state of Florida. We all know the political context of what Florida is. And so for us, having the ability to do what we did was instrumental at changing the way we do things in Florida, bringing harm reduction to our state was really an exciting feat. And we're doing a lot of cool work in Florida. So my presentation today is implementation of Florida's Infectious Disease Elimination Act, or IDEA, translating research evidence into policy and program implementation. I also want to highlight that I do not do this work alone. This is not in a silo. I'm not by myself on this. My partner in crime, Hansel Tukes, he's an associate professor in the Division of Infectious Disease at Miller School of Medicine. He really has been a fantastic mentor in this entire endeavor, and really excited to work with him in the future, especially since he is an HIV physician. Just financial disclosures. Just a quick presentation overview. I'm going to talk about the background of the ongoing overdose and infectious disease epidemics in the US. I won't spend a lot of time on that. You all know what's going on in the US. I'll talk about the syringe services programs and ending the HIV epidemic, the IDEA lab, which is our research lab at the University of Miami, and then scaling SSPs in the Florida context, which has been a very unique implementation context, to say the least. This is actually our mobile unit. I wanted to put it up there. It's been graffitied recently by one of our participants, and just is a really cool, fits in really nicely into the Miami culture. So as we all know, HIV continues to be a significant public health issue in the United States, with 1.2 million people living with HIV. We also know that the US South is disproportionately impacted by HIV, as you can see here by this AIDS view map. But we know that Florida is highly impacted by HIV, or has high HIV burden. We have 7 EHE counties. We are one of them in Miami-Dade County. Miami-Dade County, where I am, is actually #1 in new HIV infections in the country. And so this is a place where we need to scale up HIV prevention services and also treatment access. We know that the US South has been disproportionately impacted by HIV due to social and systemic issues around poverty, unemployment, lack of access to effective treatment, structural racism, discrimination, you name it, we have it in the South. We also know when we look at people who inject drugs, we've actually seen a steady decline in HIV in the last decade, from 2005 to 2015. But with Scott County, Indiana, as the kind of precipice of an HIV outbreak related to injection drug use, we're now in this world where we see an increase in new HIV infections among people who inject drugs. So these HIV outbreaks that have been popping up over the last 5 years from this Lice et al. Article really highlights the importance of implementing preventive interventions, scaling up interventions for people who inject drugs, because this has really destabilized our ability to end the HIV epidemic among this marginalized community. We also know it's not just HIV. As you can see from the CDC graph over the last, since 2013, we've seen a 50% increase in acute Hep C infections among people who inject drugs. Well, the primary risk factor is syringe sharing among people who inject drugs. We also are very terrible at doing surveillance for hepatitis C. As you can see by the line over there is the reported cases, and then the bars are the estimated acute infections. So we are really in a world of hurt when it comes to HCV surveillance in this country. Again, it's not just these viral infections. We have to also think about the bacterial and fungal infections among people who inject drugs. There's this new awesome article out by Heather Bradley that estimates that the new people who inject drug population in the United States is approximately 3.7 million people who inject drugs. And this great article from Josh Barokis and colleagues at the University of Colorado estimated that 250,000 people who inject drugs will die by 2030 due to infective endocarditis, skin and soft tissue infections, osteomyelitis, these fungal and bacterial infections. And you see really a peak in an exponential curve coming from these infections. That was actually done on a PWID population size of 1 million. So now that we have an updated estimate, we're looking at about 1 million people who are going to die from bacterial infections in the next 7 years. This is all really compounded by the overdose epidemic that we have in the United States. This is a graph from the National Institute on Drug Abuse, highlighting this significant surge in fentanyl-related overdose deaths in this country. And in 2021, there was over 100,000 drug-related overdose deaths, which is a record for our country. So this is really highlights the syndemic nature of opioid overdose, substance use, HIV, infectious diseases, and really calls for a syndemic approach to how we're going to tackle this problem. So one of our best go-to interventions that we have used to prevent HIV, prevent hepatitis C and bacterial infections among people who inject drugs is syringe services programs. Everyone know what a syringe services program is? Everyone's nodding their head, yes? All right, just want to make sure, because I know they're new here in San Diego. So at their foundation, and I'm going to call them needle exchange programs moving forward, at their foundation, they're community-based programs that provide access to sterile injection equipment at no cost to participants. They have education around safe injection practices, and they really help facilitate safe disposal of used needles and syringes in the community. They've been highly effective and shown to reduce HIV and HCV incidents, highly cost-effective and cost-saving intervention. Now, in the overdose crisis that we're in, have become critical access points to naloxone. I think 80% of all layperson naloxone that's distributed in the United States comes from syringe services programs. And now they are also including wraparound services. So HIV testing, Hep C testing, vaccination services, treatment for Hep C, treatment for HIV, and also low-barrier buprenorphine programs that exist in these programs. But they really have remained out of the federal directives for a long time. I mean, we have 30+ years of research evidence highlighting the effectiveness of these programs. But with ending the HIV epidemic plan for America, they were specifically highlighted in the prevent pillar as a cornerstone intervention that we need to be implementing to tackle HIV. And hopefully from this presentation today, you'll see that SSPs are one of the interventions that can transcend all of these pillars that are set forth in EHE. So the question is, what is going on with SSPs in the United States? As we know, the research evidence is not translating into implementation. And so we're really in this world of implementation failure with SSPs. So if you look at where the ending the HIV epidemic counties are and communities are that have high burden of HIV, particularly down here in the South, very limited access to SSPs in the Southern area. And the question is, why is that the case? So there are significant barriers to implementation around syringe exchange programs, especially in the South. There are legal and policy barriers under the Controlled Substances Act that was passed in the 1970s, that start of the drug war, have labeled syringes as drug paraphernalia. And so all these statutes at the state level need to be reformed to either decriminalize syringes or actually criminalize syringe services programs. So there's significant policy issues that happen. Funding challenges, there's no federal dollars that can actually go to purchasing injection equipment. So we're in a real tough issue where states have to set aside money to actually fund syringe services programs in their local context. We also have significant changes in the drug use trends and illicit drug supply. I mean, fentanyl, you saw the graph. It really becomes an issue when we're trying to do primary prevention. And then ultimately, we need to come up with strategies to overcome barriers and challenges. And that really is implementation at its finest. So this is a quote from Alison Ritter. I love this quote, and I always like saying this quote. But the politics of drug policy can either be zero tolerance or harm reduction. For the former, drug policy signifies a moral statement by government against drug use. For harm reduction, government's role is to protect society from the consequences of drug use, but not eliminate drug use itself. And since we as a country, as a federal government, have taken this stance on zero tolerance, millions of people have died because of it, and has really impeded our ability to implement effective interventions. So one of the strategies that we have used and continue to use in Florida and had to use in Florida, it's advocacy and engagement in the policy process. And so my entire presentation moving forward is going to be about how we actually change policy in Florida. So bringing harm reduction to the US South. This was not a short feat. It was a 10-year journey to bring syringe services programs to Florida. I was very fortunate to write this paper in academic medicine with the dean of our medical school and Dr. Tukes, talking about the 10-year journey of bringing syringe services to Florida. It really started here in 2012, where there was a study that was published on improper syringe disposal in Miami. It compared to San Francisco using NHBS data, and actually showed that there were 8 times the number of improperly discarded syringes in Miami community compared to San Francisco. So these are syringes that are found on the street, in the community, in our parks. And that publication landed on the front page of the Miami Herald and really started the entire precipice of filing legislation to actually bring syringe services to Florida. So you can see legislation was filed shortly after here in 2012, failed, filed again in 2013, failed, filed again in 2014, failed. And so we are in a position where we're in a very conservative legislature. They did not want to touch this with a 10-foot pole. And then it was branded as the needle bill, and things got issues as far as, you know, the stigma attached to needles causing drug use. And so the IDEA Act was actually rebranded as the Infectious Disease Elimination Act in 2015. There was also this new study that came out understanding that those who might be fiscally conservative really wanted to understand the economic impact of these programs or the economic benefit to having a syringe services program. So a study that was published in PLOS One estimated the cost to treat bacterial and fungal infections in our local safety net hospital, Jackson. In just one fiscal year, it was approximately $11.4 million to treat bacterial infections among people who inject drugs. So now we had the economic argument, went back to the Capitol, and were able to pass a pilot program at the University of Miami. So by statute in 2016, University of Miami could implement a 5-year pilot SSP program called the IDEA Miami SSP. It was signed by Governor Rick Scott back in 2016, and we implemented our program on December 1st, 2016, which is World AIDS Day. One of our very first successes, you can see on the back line here on our timeline, was the reduction in opioid-related overdose deaths in Miami-Dade County. So we saw a significant reduction once we started doing layperson naloxone, training our clients on how to reverse and identify opioid overdose. So that was a significant drop. And we were the only county in Florida to actually see a decrease in opioid-related overdose deaths in the entire state. So this was a huge success that we had when we were talking about the impact of our program. I'll get to our expansion legislation a little bit. So this law became effective July 1st, 2016. Like I said, it authorized the University of Miami to open a pilot syringe services program. It was a 5-year pilot, so it was supposed to sunset in 2021. No state dollars could go to fund the program. We had to operate a 1-for-1 needle exchange program. So huge, significant policy barriers that impeded our ability to implement effective interventions. So the carve out in the statute basically said that possession, distribution, and exchange of needles and syringes is not a violation of law. Originally, it was a 3rd-degree felony for a person to be handing out syringes or even have possession of syringes. So this was a huge win to have this. But the key is that you had to be enrolled in the program. So anyone who wasn't enrolled in the IDEA program could actually still be prosecuted for having or possessing syringes. So we have these great cards that we have here and these fit packs that we have where people store their syringes, but it has the legislation on it. So when they're stopped by police officers, they say, hey, I'm in the IDEA program. And usually, you know, that took a little culture shift to happen but we were able to work with police officers to not arrest our folks for coming to our program. So this is actually our fixed site. We actually got land from the University of Miami, the medical school, right on the edge of the campus, right in Overtown, which is really the hot spot for drug use and drug trafficking in Miami. We're right across the street from Camillus, which is the homeless shelter. We had an open lot of land, and we just dropped shipping containers to start our fixed site. So I love the fact that we work out of shipping containers. It's a really cool environment to be at. We started with 2 shipping containers for the pilot phase. We had 2 shipping containers, 2 staff members, myself as a PhD student volunteering. I had just come to the University of Miami for my PhD when the pilot program opened. So it was a really cool opportunity to do a lot of cool and innovative stuff with this program. So that led to the creation of the University of Miami IDEA Lab. And so the mission of IDEA, we stuck with the legislation, IDEA, and what that stands for. We kind of reverted it into how we thought about ourselves. And so the mission of our lab is to implement, disseminate, evaluate, and advocate for the health of people who use drugs. And so it really is compartmentalized into 3 pieces at the University of Miami. The first piece is the IDEA Miami Syringe Services Program. So the infectious disease department actually runs the needle exchange program and has been for the last 6 years. So we actually fund the entire needle exchange program through our research and through foundation grants and philanthropy, raising money to fund the program. And that is really the cornerstone of our entire enterprise, is the fact that we're running the SSP at the same time. As far as research goes, so when we think about IDEA research, we're really focused on health services and the translational research pathway to other programs in the country. And we're really focused on research into public policy. How can we leverage research and dissemination science to force hands in the political environment to allow evidence-based interventions to be implemented? So you can see a lot of our focus has been in harm reduction policy implementation, but now we're getting into the sphere of treatment. Like I said, I work a lot with physicians, HIV physicians, ID docs, addiction medicine fellows as well. And so we're looking to integrate all these treatment pathways with the syringe services program as the cornerstone public health home for people who inject drugs. So we want to deconstruct the healthcare system. They are treated poorly when they get into the healthcare system. There's so much discrimination and stigma from all levels of the system. So we want to say, we're going to set that aside, and we're going to rebuild the healthcare system that you all want. And that is foundational, because people who use drugs is in the foundation of everything that we do. When we're in the ivory tower, sitting there talking about designing our research grants, we have our clients in the room with us. We have our peers that are on staff with us. People who are in recovery as well come into the room. And we are working on developing interventions, developing programs, research designs, data analysis that is made for people who use drugs. So it's extremely community driven. And that pipeline then leads into our EPIC IDEA initiative. So I'm going to talk a little bit about what that is in a little. So these are just some characteristics of the IDEA Exchange program itself. So we actually implemented a comprehensive data collection system. We were still in pilot phase. We collected a lot of data because we wanted to be able to evaluate what was going on and leverage the data that we were collecting to advocate and disseminate back to the policymakers in Florida, knowing that we were a pilot program, right? So we were going to sunset in 5 years. If we did nothing to the legislation, the program would have gone away in 5 years. So to date, we've enrolled almost 2,200 people in our program, mostly minority populations, Hispanic and non-Hispanic Black individuals in our program. And that was a really intentional effort that we had. And I'll show you how we did that. Miami is 70% Hispanic. And in the first year of operations, we saw that most of our clients were non-Hispanic white. And we're like, hold on, what is going on here? So we had to really think about how we were going to leverage this program to get into those communities to promote health equity. And you can see those other demographics as well. Uh-oh. Oh, I got it now. I guess I'll have to turn around and do this. That's fine. Anyway, so some of the services that we offer at the IDEA Miami program. Oh, thank you. There we go. So we offer anonymous testing for HIV, hepatitis C, and COVID. So when COVID happened, we implemented COVID testing as well. We also have vaccination services. So we offer COVID vaccines on site, Hep A, Hep B, influenza, Tdap. We have an entire vaccine program implemented at the exchange. Obviously, we have a syringe exchange program, free condoms, first aid kits for our clients, Narcan distribution and education. We also have a free weekly clinic that's run through our medical school. So we have our Doc's Wound Care Clinic, where medical students come and actually do rotations through the needle exchange program. They work with our oversight physicians to prescribe buprenorphine, to deal with wounds, drain abscesses. They really get a cool experience of coming and rotating through the IDEA Docs Clinic. And then we also have robust linkage to care for patients who are living with HIV or test reactive for hepatitis C. We also have services for detox and substance use treatment. We also have low barrier buprenorphine induction. So that is on our right-hand side, our Bright Idea Clinic that is funded through the Department of Children and Families, where we offer free buprenorphine for our clients at the needle exchange program. So, and this was the first low barrier buprenorphine program to exist in the entire state of Florida. We also have medication management. This is a really cool protocol that we've developed and currently testing in an RCT where we actually have medication management led through peer case managers with pill lockers on site at the needle exchange program. And then we also offer linkage to methadone treatment, which we know access to methadone is a really big issue in the United States. So we launched also a mobile unit in May of 2017, and this was really meant to extend the reach of SSP services. Miami-Dade County is a big county, and there's rural parts of Miami that people don't think about. But we have agricultural farm workers that work, an hour south of the city. And so we really wanted to expand our reach into the community. And so taking a data-driven approach, we always monitor everything that's going on at the program so we can make real-time distinction changes in the services and how we're offering our services. So one of the things that we were looking at on a year-by-year basis was the breakdown of demographics of clients that were enrolling at the fixed site versus the mobile unit. And we did a terrible job at engaging people of color, Black and brown communities in Miami. And so we made it intentional for our mobile unit to enroll more and more people of color into the program. And we did that through a community-driven approach. We actually hired clients from our program to use the mobile unit. So they were staff at the University of Miami, and they reflected the community that they came from, Liberty City and Overtown. And so you can see on the right-hand side, the mobile unit, when we implemented that in 2019, 2020 was COVID, but we saw a significant increase in enrollments of Black folks, Hispanic folks coming to our mobile unit services. So I really like that graph a lot when I see that. One of our first successes, like I said, is the reduction in overdose deaths, and this continues to be persistent to this day. So we provide training and provide access to free naloxone or Narcan for our participants, family members, and friends of participants, and also our law enforcement partners. We have law enforcement drive into the needle exchange program, ask for Narcan. We are then able to talk to them because half the time they're coming there and saying, hey, my officers are overdosing on fentanyl, I need Narcan. And we have an opportunity to tell them that's not true, that can't happen. And so it's a really cool education piece to change the culture that's happening in Miami. But today we've done over 10,000 boxes of naloxone or Narcan, and have almost 3,000 self-reported overdose reversals among our clients. And this was a new report that came out of the medical examiner's office in Florida. And for the first time ever, Miami-Dade County is a green county, which I don't think that ever existed before. It's obviously not the lowest, but we are actually colored green. And I don't know why they did the coloring this way. It sounds like a Florida thing to make it a weird color scheme. But a lot of counties are red and are in a real issue when it comes to overdose deaths, but we're actually being pretty successful in Miami. And that's really from, historically having this naloxone program that other places don't have. So a little bit of my Miami research and evaluation. I'm going to grab some water real fast. So one of the first successes that we had was implementing testing at our site. So this was a project 3 months into my PhD when I was a student. I wrote a grant to Gilead and got funded to implement HIV, hepatitis C testing, and linkage to care. And with that implementation, happened in February of 2018, we moved from an opt-in testing framework where clients came in and said, hey, would you like to receive HIV testing or Hep C testing, to an opt-out framework where we said, this is standard of care. We're going to test you for HIV. Do you have any questions? And so when we changed to an opt-out testing policy, we actually saw a significant immediate impact of our testing uptake by 42%. And that persisted across time. As you can see, the graph is a little cut off there. We've had consistently increased and sustained impact of testing uptake of well over 95% among clients that are enrolling in our program. This was really the first success. I actually received an email that this will be in the CDC compendium for HIV interventions. This is the first testing intervention for people who inject drugs and the first one in the SSP context. So it's really cool to see CDC adopting some of the structural interventions that we're working on in Miami. that actually led to the identification of an HIV outbreak. So we implemented our testing in February 2018. By March 2018, so a month later, we had 3 new seroconversion cases, because part of the protocol was for those who were testing negative, we wanted to do follow-up testing every 3 months to monitor for these things. And when we implemented our testing, we also implemented a data-driven approach where we actually had weekly reports that get generated out of our REDCap system that's sent back to the staff members for us to monitor new things that are going on in our program. And one of the things we really wanted to monitor with this program, with this testing protocol, was new infections, right? So we were able to see when they tested negative with us, and then we can monitor when they tested positive. So we had a big red line item on our weekly report that said new HIV infections. And once we implemented the testing, you can see very short after there, those red dots are when we received those HIV reactive tests for our clients. You can see it proliferate across time. And then the blue dots is when we actually were able to get them linked to care and virally suppressed. So we responded to this outbreak. We worked with the Florida Department of Health to respond to this outbreak. I would say it's a cluster, not an outbreak. And because we stopped the outbreak from happening. And we embedded a DIS worker from the Department of Health at the needle exchange program. They said, we can't find these people. And we're like, we just saw them yesterday, so we know who these people are. And we were able to work together and build that partnership. It's really a translational shift in Florida. The Florida Department of Health actually opposed the SSP legislation back in 2015 and 2016 for the pilot project. So they didn't like that we were doing syringe exchange programs. But now they saw the utility of having an SSP and our ability to respond to an active, ongoing HIV outbreak in our community. And so part of that, and I know Susan would love to see that little network over there. You can see the molecular cluster network that we did as well. But really the cornerstone of this is we were able to get people involved in the outbreak. We had 7 acute seroconversions, all linked to care, all viral suppressed within 70 days, which is still too long. That's still too long. We need to do better, especially for clients that were previously diagnosed with HIV, those yellow circles over there. The viral suppression rate for the same protocols that were offered to them to link to care was about 53%. So there was differential viral suppression among those clients. So we really wanted to optimize our pathway. There was actually no treatment pathway before we started. So we were starting from scratch, figuring out how we get someone who is injecting fentanyl 15 times a day that lives under the bridge to go into the HIV clinic. And it was a 2-month time frame to actually go from being diagnosed to actually receiving an appointment to even start the process to get into HIV care. So we worked with our clients and took a community-driven approach and did a lot of process mapping and figuring out how we were going to revolutionize how people who inject drugs access HIV care in Miami. And we landed on what we call our teleharm reduction intervention. So it's a telehealth enhanced intervention, multi-component intervention, where we use telehealth to bridge that digital divide for clients who might not want to come to the SI clinic or come to the Jackson Ryan White Clinic in Miami. And so we do all the care through the needle exchange program. So they come in, they test reactive for HIV. They're immediately referred to our community engagement team, where they are met with a peer support worker who connects them via iPad to the physician. So the physician can be anywhere in the county. They could be at home, they could be in the office, in the ivory tower, but they're able to connect with the patient there, have clinical assessments, prescribed their treatments. So we do this for HIV treatment. We are now adapting it for PrEP, medications for opioid use disorder, hepatitis C cure. The medications are either delivered or picked up by the peer support worker directly to the needle exchange program, and they're automatically entered into a medication management protocol. So we have on-site pill lockers at the needle exchange program where patient's medication is stored, and then they work with the peer navigator every single week to do weekly medication drops. So they go out there into the field, they bring them their syringes, bring them naloxone, and here's your Biktarvy as well. So it's a really cool, nice, appealing package for our clients to have access to all the harm reduction supplies, as well as the peer support worker and their HIV treatment as well. So we won a few EHE supplement grants to do some implementation planning around this intervention, develop it out, figure out how we're going to implement this. And we launched in January of 2020. So we actually were there ready to do telehealth when COVID hit. So this entire pilot ran at the first year of COVID, which is pretty remarkable to see the results of the pilot project. But we published this in Drug and Alcohol Dependence, our pilot results. And so you see for the 35 clients that we enrolled in the pilot, all of them were able to enroll in Ryan White, meet with a case manager in real time, completed a telehealth visit with a provider, and received ART the same day. So all 35 received the medication within 3 hours directly to the exchange, and started the treatment same day. And we had 78% viral suppression at 6 months, which is remarkably high. And I think some people who have worked in SSPs before understand that this is a great result, preliminary result for this study. And I'm going to talk about it a little bit. We're testing this intervention now in a randomized control trial under our Avenir Award. So that is just a little bit of the research and evaluation we've done. Like Natasha said, we have published extensively from the Miami context. And this is really more focused on the impacts that it has on dissemination. What we heard from our policymakers, heard from our stakeholders when we were doing our advocacy work is that we were talking about the global evidence for SSPs, right? Australia, Europe, California, New York. And that was not hitting home for legislators in Florida. So we really were intentional to make sure that we did our analyses in the Florida context and evaluated our program that was going on in Miami. Because like I said, pilot program, we were going to sunset in 5 years. So we had to really do extensive implementation, evaluation, research on new protocols as well. And so we published probably about 28 papers off of the Miami pilot project, just to show that we could implement student wound care. We did cost analysis looking at how much it costs to implement and operate. We showed that we were actually reducing syringe sharing behaviors across time in our program. We also looked at acceptability of doing buprenorphine and PrEP implementation. We also worked under a 1-for-1 syringe exchange policy. And so I did an analysis that showed that 90% of our clients actually never reached sufficient syringe coverage. So that's every time they report that they're injecting, they have one clean syringe for that. So again, 1-for-1 policies are ineffective, and we all know that they're ineffective. But we wanted to show that it was ineffective here. And this was really important as we were thinking about, all right, we don't want to be a pilot program anymore. How are we going to advocate for expansion? How are we going to bring syringe services to the rest of Florida? It was only happening in Miami-Dade County. So we were pulling clients from across the entire state coming to the University of Miami syringe exchange program. And so it was really intentional for us to think about how we were going to advocate for expansion. So changing state policy. Oh my goodness, this brings me back to PTSD times. So we were very intentional in how we disseminated our information. Like I said, the pilot project started in 2016. And by 2018, we felt comfortable enough that we had preliminary evidence on why we should be expanding this program across the state. 2018, we went to the legislature. We passed it all the way through the Senate, and the Senate approved it. It got caught in the House side on our last committee, the third committee on the House side. In 2018, if everyone knows what happened in Florida, we had the Parkland shooting that happened. And so our SSP legislation ended up being held hostage because our bill sponsors would not support the legislation that was set forth in response to the Parkland shooting. And so we cried for a few months because the legislation failed. Session's only 60 days in Florida. So we were in Tallahassee every single week. And I was a student taking classes. I probably missed half my classes that semester doing this advocacy work. But we failed in 2018. We regrouped. We redesigned how we were going to disseminate our information. And we really leveraged dissemination science to figure out how we're going to target policymakers. We know that different policymakers want to hear different things and different arguments. And so we really were strategic on how we were going to disseminate it and how who we're going to disseminate to. So we use one localized data. So we only use data from Florida to highlight the impact of SSPs. Again, we talked about the CDC supporting these programs, but really a cornerstone piece to this was EHE that happened, right? That's a Trump administration thing. And so we were able to link the fact that Trump supports syringe exchange programs into the narrative that we said to those who might be fiscally conservative, might fall on the other side of the aisle at times. We also use student advocates. So medical students, myself as a PhD student, we were up in Tallahassee every single week advocating for this, meeting with senators, meeting with representatives, and we used this little one-page sheet to disseminate information about the pilot project. It was really cool to see because when we sat on health committees and did our presentations to the health committees as the bill was moving in 2019, you could see all the representatives, all the senators had the one page. We used it as a leave behind, and so they were able to, basically, we trained them on how to advocate on behalf of syringe exchange programs. And this was really impactful because we had both sides of the aisle, people who were against the pilot legislation in 2016, coming out and speaking for the expansion legislation in 2019. We also had testimonials. So thinking about different narrative streams, it's not just researchers that should be there. We had people who use drugs that were in the Capitol with us talking about it, and also moms who have lost their children to the overdose epidemic as well. They are highly effective at reaching policymakers. And then we used tailoring messaging. So when we walked into, let's say, a Republican's office at the time or a fiscally conservative person, we led with the bottom half of the sheet. So we trained all of our medical students to lead with the economic argument and then don't talk about needle exchange, right? Talk about HIV prevention, talk about all these other things, but lead with the economic argument. But when we talk to those who might be more social justice oriented, we talked about overdose prevention. And that's really, we didn't really talk about needle exchange. We didn't say needle exchange. We didn't say anything about that. We really targeted the economics part of it and also the overdose prevention aspect of our program. So this was gaining a lot of traction in the legislature in 2019. So there was tons of articles. We did interviews on NPR. We were on the Miami Herald. We also talked to Associated Press and got a lot of highlights on what was going on in Florida. And as you can see, Florida is the latest Republican-led state to adopt clean needle exchange programs. This right here, this is a quote from one of the senators, Senator Bradley. He actually hated the pilot project, Would not vote for it because I'm never voting for this. And he went on record and said, I just want to say, when I started my career in the Senate, I voted against the pilot project and I was wrong. And the results speak for themselves. It's very good public policy. So senators who are against this, hardcore against this, were now coming out in favor of the legislation. So this was us in the Capitol on the House floor. It actually passed at 11:30 at night. It was after a 3.5-hour debate on abortion, the 15-week abortion ban. And so this was myself, my mentor, Dr. Tukes, our representative from the House. They had a co-sponsorship from a Democrat and a Republican, Representative Jones, who's now a senator in the House, or sorry, a senator in the Florida legislature, and then Representative Placencia. And so that was a huge win for us to pass this legislation. But this was my favorite photo that we took. We were there with our moms who were up there, Cindy Dodds, Joy Fishman, Julia Negron. So they were there to witness the passing of this legislation, which was instrumental. It passed the Senate 40-0. It passed the House 111-3. And Governor DeSantis signed it into legislation on June 23rd of 2019. So now we had statewide expansion of syringe services programs. However, the way we wrote the legislation is not how it passed. So we wrote in an opt-out framework. So if we pass this, all counties could implement. Well, they didn't like that, so they wanted an opt-in framework. And so now counties have to pass local ordinances to actually implement syringe services programs. They also said no state dollars could go to fund the programs, a big implementation barrier. And they stuck to the one-for-one exchange policy in the state. So now we're in statewide implementation phase. So I currently lead the statewide implementation of SSPs in Florida. And we use the infamous EPIS framework and EPIS implementation framework. I know Greg Ahrens and the team are here, are really the founders of this. And so we worked with our community partners to figure out how are we going to implement syringe services programs. I'm in Miami. I'm a one-man show down here. We have our whole team. How are we going to facilitate this across the entire state? And so I did a presentation to all of our community partners across the state and talked about how we can leverage implementation science and implementation framework to support the implementation of these programs. They loved it, they adopted it, they embedded it into everything that they were doing as far as on the local context. And so we use the EPIS framework, as I said, different phases of the implementation process. And now we're targeting specific strategies to deploy across those implementation phases. But one of the things that they wanted to change was the name of EPIS. So it's exploration, preparation, implementation, and then collaborative sustainability. This was really a theme from our community partners that said, we are not sustainable unless we're all sustainable. And so they wanted to make it epic in too. So we have the EPIC Idea Initiative, which is really focused on large-scale implementation of SSPs in Florida. So thinking about the economic argument and thinking that local counties have to pass local ordinances, we did this study that was published in Clinical Infectious Disease, looking at the economic burden of bacterial infections in the hospital systems. So we used ACA data, the Administration for Health Care Agency, I think it is. So all claims data of hospitals in Florida. We used ICD-10 codes to identify a cohort of people who inject drugs through bacterial infections and drug use, ICD-10 codes. And we estimated that the economic burden in 2017 to the entire state of Florida to treat bacterial infections was approximately $380 million to the state. It's a huge economic burden because a lot of our clients are either on Medicaid, we don't have Medicaid expansion, so they're uninsured in Florida. But we were really intentional. Oh no. Fine. So we're really intentional on how we disseminated this information. So one of the appendices that we put in the publication was a county by county breakdown of the economic burden of these infections. And so you can see here how that kind of lays out and plays out. And because of that, we were then empowering our local contacts to go into their county commissions, advocate for these programs based on the evidence and the data that we were presenting here. So you can see we have 10 counties that have actually moved forward and passed local ordinances to actually implement these programs. We also did our own vulnerability assessment. So anyone who's familiar with Manhandle's CDC vulnerability assessment, there's methodological issues that came with that paper. However, it had profound impacts when it comes to implementing syringe services programs. Kentucky had no programs, right? In 2015, they passed legislation. Now Kentucky leads the country in the amount of syringe services programs that they have in their state. I think they have 83 programs now. So they're ahead of California, and they started in 2015. But that really was on the back of, hey, you have tons of vulnerable counties to HIV outbreaks among people who inject drugs. So I thought about that as, all right, this is a great advocacy tool. We need to do this in Florida and present this data. So I did updated the methodology a little bit and used machine learning, lasso regression, to predict HIV outbreaks in the state of Florida. And then, of course, published it at the county level to highlight which counties were the most vulnerable in Florida. The analysis was done at the zip code level, but we aggregated based on county. And what's interesting here, like I said, we had an HIV outbreak that happened in 2018. These data come from 2017 because we're always years behind in getting access to state level surveillance data. But Miami-Dade County had 2 vulnerable zip codes that were identified in this analysis. One of them was where the outbreak happened in 2018. So this actually had some type of anecdotal validity that we were able to predict outbreaks among our population. So thinking about disseminating this information, in our exploration phase, one of the primary targets that we're focused on is passing legislation or gaining support for SSP legislation in the local county. And so we do a kind of train the trainer type of model where we leverage the coalitions that have already been built in these counties to train them on how to advocate for syringe services programs. I can't drive to every county and talk to every county commissioner to get them on board with this program. So this is a way for us to do large scale implementation. So this was a data dashboard that I created where we integrated all of the research that we were doing in Miami onto the dashboard with state level surveillance data. And we were able to train our local advocates on how to work through this little one-page sheet. And it could be a leave behind then that you can have for your police officers, for your county commissioners. And this has been really impactful. Like I said, 10 counties have passed local ordinances, and all of them have been disseminated this way. So hopefully there's some validity to that. There's some evaluation we need to do if this is actually changing perceptions of policymakers. But that's really the next phase of what we're going to do is large-scale evaluation of our implementation efforts. So where are we now? We currently have 5 sanctioned syringe services programs. We were able to implement 4 new programs in 2020 and 2021 during the pandemic. Everyone is networked and connected. We actually are the data warehouse for the entire state. So all syringe services programs run on our REDCap data system. We've harmonized our metrics. We've built data products out of the REDCap system to operationalize tracking of supplies, syringe distribution, and really automate reports back to the state for them to see what's going on in real time. So we have 5 programs that have been open and implemented, but we're really working in about half the counties. A lot of counties are still in the exploration phase. So we're still working on building those coalitions out, engaging with local law enforcement, gaining support for the local ordinances. But we work with our partners at the Florida Harm Reduction Collective to build out this entire implementation project. So what's next? We're scaling up SSPs, but what are we doing as far as innovation? So like I said, our teleharm reduction intervention is being tested right now under our Avenir NIDA award. So we're doing a 3-site randomized control trial. It was sold as a 2-site. We got an administrative supplement to expand to another SSP program that's in Broward. It's a strictly mobile site, just as the IDEA Tampa site is. So we have 5 SSPs. We have IDEA Miami. We have the Spot in Broward. We have Flash Exchange in West Palm. We have IDEA Orlando in Orange County. And then we also have IDEA Tampa over in Hillsborough County. So we have 5 of the 7 EHE counties that are covered now with syringe services programs. So this is, like I said, 3-site sample size is 240. We're testing their intervention compared to treatment as usual, which is usually patient navigation for these programs. SSPs don't have the infrastructure and capacity to do a program like this, and that's where we come in as an academic medical center and have the ability to implement these things in real time. So we're testing the intervention compared to treatment as usual. Secondary outcomes are that we think that teleharm reduction will be superior for MOUD initiation and retention, and also HCV cure. And we're also doing a cost effectiveness analysis. So our trial is called Project T-Sharp. Our protocol paper was just published 3 days ago. So if you're interested in reading the protocol for the study, that's now available. We are also waiting to hear back on an R1 that was submitted recently. It just went through advisory council. Fingers crossed it's pending. To actually adapt this intervention for PrEP and for medications for opioid use disorder. So again, making this intervention status neutral. So people who come to the SSP can have the same resources, same services, if you're at risk for HIV or if you're living with HIV. NIDA also loves our program. So they came and did a whole video series about harm reduction, the intersection of HIV and substance use research. And so I usually end with a video to show like how this kind of works in real time. But I always go over because I talk forever. So there's a series of videos online that you can go check out the work that we're doing, which is really cool to see NIDA embracing a lot of the work that we're doing in Miami. We also are changing the way that we do hospital care. So I know some people might be interested in what do we do with people who are hospitalized with bacterial infections. I talked about it a lot. There's a huge economic burden. So under the leadership of Dr. David Sirota, he's an ID addiction medicine physician at the University of Miami. We actually developed what we call the SIRI team, the Severe Injection-Related Infection Team at Jackson Memorial Hospital. Largest safety net hospital in the United States is in Miami. There's 1,600 beds. And so we implemented ID addiction consult service with longitudinal care post hospitalization for clients that were hospitalized with bacterial infections. So we published a paper talking about the intervention design. We published preliminary outcomes that you can see here. So compared to a historical control, we saw a significant reduction in readmission rates among our clients. A lot of clients that come and are hospitalized with these infections leave against medical advice, or what we call patient-directed discharge, because they're going into opioid withdrawal, they aren't started on medications in the hospital, and so they leave, and then their infections get worse, they're readmitted, and then they have these long stays because now it's progressed to endocarditis cases. And then we also published a study recently on looking on implementing this entire intervention in the hospital setting. So this is actually now it's been adopted by CTN. It's now a CTN 121 trial led by Lisa Metch, Carlos Del Rio, David Sirota. I'm leading the implementation science component for this study, but it's our high series study, which it's a really cool, David Sirota is amazing with naming studies, but it's a holistic intervention for severe injection-related infections. So this is going to be launching this year. It's a 6-site randomized controlled trial with 6 hospitals in the US. 480 patients will be randomized to our SIRI intervention versus standard of care. And we're going to be, the primary outcome is going to be readmission or death on the 4 months post-hospitalization. So that's all I have for you today. But this was, like I said, this has been a team effort over the last 6 years. It's been really exciting to work with all these people. This is not an exhaustive list. There's probably thousands of people that I can thank for all of this work that we've done in Florida. But I'm excited to hear any questions and field that. So thank you.
Okay, thank you so much, Tyler. That was a phenomenal presentation and just incredible impact that you've had in such a short amount of time. Should we start with questions? Any questions in the audience? Yeah, here.
Hey, my name's Scott Latender. Grew up in Broward.
Oh,
So
South Florida.
Yeah. So but my dad managed a motel near A1A in Las Olas that used to be the epicenter for teenage runaways. And
Yeah.
it just highlights for me, the complexity of the environment that you're in and the praise that you deserve and, for everything you've accomplished. But, South Florida is a highly complex environment.
Mm-hmm.
And, what I'm thinking about is, questions I'm thinking about. One is, you touched on reaching out to agricultural farm workers. You touched on reaching out to different communities. You mentioned, 70% Hispanic and Dade, but, also the Haitian community and everything else. I'm sure you're addressing all that to the best of your ability.
Yeah.
But the questions that come up for me is, the incredible amount of funding you've gotten with a lot of hard work.
Yeah.
And, how we can replicate some of that here. And, you're another question, which is completely naive on my part, but you're sort of addressing the very important part after addiction occurs. And, with a lot of people, move into South Florida still, and for all different sorts of reasons, sort of the party and tourist culture,
Yeah.
the immigrants that come in from all over, what can be done to address the social aspects that lead to stigmatization and cause people to go down an addiction path? Is there anything in the state that can be done to sort of address the pre-addiction part of it as well? I know that's not
Yeah.
what you do. It's
I was gonna say, that's not my
very broad
wheelhouse.
question, but it seems important to try to address it in both places.
Yeah.
You're doing this really important part, and again, give you a lot of credit for everything you've accomplished. But this other part of it too seems to me, the social part of it seems really important. And what's been going on in Florida in the last 20 years doesn't seem very open to addressing some of those challenges.
Yeah, absolutely. I would say I'm not, that's not my wheelhouse. Primary addiction prevention is not my wheelhouse by any standards. And so I will not speak to that. I'm not an expert in that, so I don't have an answer for you. But the Florida context is so interesting. Even in our clients that come to the exchange, we have specific subgroups of people that come. Now in the phase of fentanyl, we have a lot of people that are injecting fentanyl and stimulants. They're injecting cocaine, methamphetamine, and we showed that they were at higher risk. So they had higher risk behaviors for HIV, for Hep C, more likely to be unstably housed, inject in the streets, do all of the above. But then we also had this entire group of people that were coming to the exchange who only injected methamphetamine, lived on South Beach, high income families, who also engaged in chemsex. They were coming to the SSP. I was shocked, the fact that they were coming to the SSP. You can buy syringes on Amazon if you wanted to. You can do it yourself. And so for them to come engage with us, drive up in their Mercedes as other people are coming up in their bikes, it's a really weird environment that you don't necessarily see in other contexts. Even when you go across the state into Tampa, you see half of the clients that come to their SSP inject methamphetamine, but they're all unstably housed and more likely to be in that polysubstance use class. And so it's so interesting, even within Florida, there's high variation when it comes to what drugs are being used and how that leads to risk. So I don't know if I answered your question at all, but the reality is that, there's no state funding that goes into these programs. And so everything that we've done as far as expanding, like I said, we started with 2 trailers, 2 staff. We now have 5 trailers, 2 mobile units, 16 staff, 5 faculty that are working on this project in Miami and expanding in Florida. We just need more funding and more capacity build out to be doing this. I mean, having just one SSP in Miami-Dade County is insufficient to reach all of the clients. We're working on developing a population estimate in Miami, and hopefully we can work with somebody here to also think about doing that. But we know that we're probably reaching 10-15% of all clients that we really need to be engaging with. So there's tons more work to do on that front. And I'll focus my efforts on that versus the primary prevention. But we do have researchers at University of Miami who are really focused on school context, preventive interventions for addiction and substance use. It's just not my wheelhouse.
Great talk, amazing work. And just because I guess one of my questions is, you have an incredible infrastructure in Miami-Dade, lots of boots on the ground, and lots of volunteers. And just one of the things you mentioned in a previous talk was how you cope with the one-to-one syringe exchange by going out and collecting used syringes. And I'm just curious how you are implementing that kind of infrastructure in these other counties, because that's a huge scope of work.
It is. So by Florida statute, the way the legislation was written, which is a kind of a downfall of the legislation as well, is that we expanded so quickly and had so many services during the pilot phase that the Florida legislature looked at that and said, that's how we should do it. Foundational SSP needs to have integrated HIV testing, integrated Hep C testing. You have to offer naloxone. You have to offer buprenorphine. Like, now all of a sudden the SSP legislation became this comprehensive, monster of what you're supposed to be doing with SSPs, when at their foundation, they're really simplistic programs to implement. So really they're like, by law, they're kind of complex to implement. And so part of that too is hospital systems can implement them, aid service organizations can implement them, nonprofit agencies can as well. And so in Tampa, for instance, we replicated our model to an extent and implemented with University of South Florida and Tampa General Hospital, just like we have University of Miami, Jackson Memorial Hospital. So it's again in that academic research setting. And so they have, over 1,500 clients that have already enrolled in their program in the first year and a half of it operating. But I think the most significant barrier and the thing that we kind of keeps me up at night is the funding aspect. There's no funding for these programs. County commissions are so hesitant to even start it. Our organizations that are running the programs are hesitant because I don't want to hire somebody and have $50,000 and it's going to run out in 6 months. And so as far as implementation or even sustainability of these programs, we're not even close to the level that we need to be at. But I can't do it all. And so, I'm gonna have a baby soon and there's other things in my life that I have to deal with. But, it really has been like sleepless nights, flying to Tallahassee, advocating, then making up my classwork, writing grants and doing things, as a PhD student, working, tirelessly to make sure that this program stays funded. Very fortunate to work with Dr. Tukes, who also has that mentality. So we really have that go get and conquer mentality in Miami. And it's really trying to empower other locations to have that type of mentality, which is really hard to do sometimes. Yes.
Okay, thanks. Sure. There's a question online.
Oh.
Maybe, okay, I think for fast, we can fit in 2 quick ones. This is from Miley Karras. We've been trying to implement a similar inclusion health service for SUD here for years. A major struggle has been engagement with hospital leadership. Was the cost analysis the censure for you?
Yes. Yes, it was. So we did an economic evaluation of just Jackson, and we set up a presentation with high-level administration to talk about, what can we do to reduce readmission, reduce hospital expenditures? I mean, if you think about the policy context of the hospital, they don't want people coming back to the hospital, right? That's a metric that they're really focused on. And so you have to harness what those individuals want to hear, and provide them information that's going to drive that buy-in. So we did a presentation to admin and they said, all right, we're going to set aside dollars to fund this pilot project. We also leveraged the CFAR that funded the research aspect of it as a pilot project. And now it's a, $12 million CTN trial. So hopefully, other places can see it. Like I said, we published 3 papers on the implementation, the intervention design, and hopefully that can leverage taking it to other contexts and other people that might want to implement similar consult services in their hospitals.
Love it. Anyone interested in economic evaluation, please contact me or the Center for AIDS Research Biostatistics and Modeling Corps. Okay, last question. We have 1 more minute.
Hi, this is a great presentation. So thank you so much for sharing your work with us. I was curious, you're facing a lot of challenges that are not necessarily unique to Florida, but definitely need to be contextualized when dealing with them in Florida. And we have some of those similar challenges here with expanding our SSPs. We have some political partisanship issues, right? The county may be in favor of it, but there are some cities that are not, and those create barriers. So I'm wondering, from your work in Florida, are there any policy level implementation strategies that you are thinking of? And I realize that's a really hard question to answer, so I'm going to let you off the hook a little bit. But, I'm just curious where you're thinking of,
That
how
can
do
be
you,
applied to this context
or
or just
or
in
in
general?
Florida, what you're thinking about in Florida, you need to get funding, you need to scale up implementation, but you need to win over legislature to do that. So I'm just curious if you have any hunches about potentially effective policy level implementation strategies
Oh,
you'd
man.
love to try.
Oh, man.
Yeah, sorry about that.
So I talked to Susan about this too. And this is the question I get most often post presentation when I do this. We did this presentation actually to CDC leadership, and they asked the same question, how do you advocate? What is the best? If you had to put all your money in one basket on one implementation strategy focused in the policy context, what would it be? And I was like, I have no idea. I literally have no idea. When we passed this legislation, it was like a kitchen sink approach. We threw everything we could at these legislators to get them to support the legislation. A lot of times policymaking happens, it's sausage making. So it happens behind closed doors and informal meetings and things of that nature. So as far as this is what I think is the most effective strategy to use, couldn't even tell you in the closest mind, what it was actually the most effective strategy. All I know is that it passed and thousands of lives have been saved because of it. And that's all I care about at the end of the day. But my research brain is literally sitting there saying, what did we do that was effective to get a Republican-led legislature to adopt statewide expansion of syringe exchange? I mean, there's places like Pennsylvania, for instance, they don't even have statewide expansion, but they have one of the oldest, largest SSPs in Philadelphia in the entire country. And so there's all these different contexts that this can be applied to. But I would say leveraging moms who have lost their children to the overdose epidemic was a really effective strategy to talk to policymakers. And unfortunately, the Trump administration EHE thing, I think, might have driven some people into supporting the legislation as well. So I don't want to say that out loud, but I'm sorry that I did.
Okay, thanks. Thanks so much again, Tyler. I'm
Thank you.
afraid we're out of time. I know there are more people that have questions. Thank you again so much for coming. Fantastic presentation. Really great to have you.
Thank you.
Thanks, everyone.